Hello everyone, this video is about aortic dissection. So aortic dissection falls under acute aortic syndrome, which also consists of intramural thrombus and penetrating atherosclerotic aortic ulcer. So aortic dissection means breach in the integrity of aortic wall, which allows arterial blood to enter tunica media, which is split it into two layers, creating false lumen alongside of true lumen. So here is an aorta. This is the true lumen. In aortic dissection, blood is dissecting the walls of the aorta, creating a false lumen. This is the false lumen. This is true lumen. So it creates false lumen alongside of true lumen. What are the risk factors? First one is age. It is usually seen in men aged 40 to 60 years with antecedent hypertension. So remember, hypertension is the major risk factor. It can also occur in younger adults with connective tissue disorders like Marfan syndrome and Ehlers-Danlos syndrome. It can also be due to iatrogenic causes like during aortic surgery, intra-aortic balloon pump, or aortic valve replacement. Pregnancy also can lead to aortic dissection, which typically occurs during or after third trimester. In pregnancy, it may be related to hormone-induced vascular remodeling and the hemodynamic stresses of the perinatal period. Other aortic conditions like aortic atherosclerosis, aneurysm, and coarctation can also lead to aortic dissection. Now coming to pathogenesis. All these above risk factors lead to tear in the tunica media of the aorta. Then the blood will flow through the tear into the media and dissect it. There will be formation of false lumen. This will form hematoma. This hematoma can extend retrograde towards the heart, or distally it can extend up to iliac and femoral arteries. So this is an aorta. Let's say here is a dissection, and we know aorta arises from the heart. This dissection, it can move distally up to the iliac and the femoral arteries, or it can move proximally up to the level of heart where there is aortic valve. If it reaches up to the aortic valve, then it can cause aortic regurgitation. And this dissection can also rupture into various spaces, creating serious complications. What is double-barreled aorta? So you can see in this picture, blood is dissecting through this tear in the proximal part. It is forming a false lumen here, and it is coming out from this distal tear. So it is sort of creating a double barrel right here. So this is what we call as double-barreled aorta. Now on to the classification of aortic dissection. It is classified into two types, type A and type B. So type A is when aortic dissection occurs in the ascending aorta. If it spares the ascending aorta, we call it as type B. All right. In type A also, it can involve both ascending or descending aorta. In that case, we call it as Divaki 1, or it can involve only the ascending aorta. We call it as Divaki 2, and Divaki 3 means type B. So type A dissection involves the ascending aorta. Divaki 1, which involves both ascending and descending. Divaki 2, which involves only the ascending aorta, and it's the most serious one. Type B, it spares the ascending aorta. It is seen in only the descending aorta, and we call it as Divaki 3, and it usually begins distal to subclavian artery. So here is the subclavian artery and distal to it. Now coming to the clinical features. There is sudden onset of excruciating chest pain which radiates to back between the scapula. Reduced peripheral pulsations. Asymmetry of brachial, carotid, or femoral pulses. So there can be brachiofemoral delay or radioradial delay. Sign and symptoms of aortic regurgitation. As I've already explained, if it moves retrograde towards the aortic valve, it can cause aortic regurgitation, and that can manifest as so. Now coming on to the complications. We know there are many branches of arteries coming out from the aorta. And if there is any dissection, then this can compress these branches. So if it compresses coronary arteries, it can lead to MI. Carotid artery can lead to stroke. Spinal arteries, paraplegia. Celiac and superior mesenteric artery, it can lead to mesenteric infarction with an acute abdomen. Renal artery, renal failure, distal arteries, then ischemia of limbs. It can move retrograde towards the aortic valve, causing aortic dissection. The most serious complication is, however, rupture of dissection. It can rupture into peritoneum, causing peritonitis, in pleura, hemothorax, and in the pericardium, causing cardiac tamponade. However, these are only the local effects. If it ruptures, then there is a huge amount of blood flowing out of the systemic circulation, and this can cause shock. So, what investigation we do? MRI and CT are the investigations of choice. So here in the MRI, you can see this is the aorta, and it's a there is a small septum separating. So this is the true lumen, and here is the false lumen. And in the CT also, you can see this is the aorta, and this is the dissection. This is the false lumen and the true lumen. X-ray is usually not that fruitful, but if we do, we can see broadening of upper mediastinum and distortion of aortic knuckle. On echocardiography, there can be aortic regurgitation, and on ECG, it will show left ventricular hypertrophy in hypertensives. Under management, treatment should be urgent to reduce mortality. Usually, the type A cases require emergency surgery, with that is replacement of ascending aorta. Type B, they can be treated medically unless there is rupture or vital organ damage. So medically, we can give pain control medications or antihypertensives such as beta blockers, calcium channel blockers. What surgery we do? We do percutaneous endoluminal repair, where we fenestrate the dissection so that the blood can return to true lumen. Alright, so if it's a dissection, then we fenestrate here so that the blood can return to its true lumen. Implanting a stent graft placed from the femoral artery is also an option. Thank you.